thanks for this amazing, amazing turnout. This is just fantastic and a clear sign that the dream is alive and well. And we're going to share with each other because you came here for a purpose. And as people stream in, I'll start with the introductions and hopefully everybody will catch up. My name is Tony Denton. I'm the Executive Director for University Hospitals and Chief Operating Officer of our hospitals and health centers. And I want to bring greetings and welcome to all of you for being here on our health system, Health Sciences campus, welcoming you to the 2013 Martin Luther King Jr. Symposium for the U of M Health Sciences programs. In honor of Dr. King's legacy and inspiration, this is the 23rd annual occasion that the Health Sciences programs have collaborated to celebrate his life, to reflect on Dr. King's humanitarian and service commitments, and to hold dear to the increasing and lasting importance of his and our dream. So the Health Sciences programs co-sponsoring this symposium include the University of Michigan Schools of Dentistry, Medicine, Nursing, Public Health, Social Work, the College of Pharmacy, along with our hospitals and health centers. I would like to acknowledge leaders present from the following sponsoring units. And if someone is coming late, please let me know and I'll acknowledge you as well. Dr. Ora Peskovitz, our Executive Vice President for Medical Affairs and CEO of the health system. From the medical school, Dr. Jim Williscroft, Dean. From the College of Pharmacy, Dr. Frank Ascioni, Dean. From the School of Dentistry, Dr. Peter Polverini, Dean. From our School of Public Health, Dr. Martin Filbert, Dean. And I understand that Gil Oman, our former Executive Vice President for Medical Affairs, has also joined us today. Also, I'd like to acknowledge Regent Julia Darlow, who has come to join and be with us today as well. In addition, I want to acknowledge Ms. Deborah Childs, our Chief Human Resources Officer for the health system, and Dr. Joe Kolars, if he's here, our Senior Associate Dean for Education and Global Initiatives in the medical school. Together, they partner as leaders charged to help implement our health system strategies in the areas of diversity and inclusion. The occasion, why are we here? Today, we celebrate Dr. Martin Luther King Jr. with this year's theme, 50 Years Later, Revolution of the Dream. Our keynote speaker, Dr. Carmen Green, will address this theme as she presents Unequal Burdens and Unparalleled Opportunities, Achieving the Dream for Health and Pain Management. But I think it's important that first we reflect on the theme for all of the university's 2013 Martin Luther King Jr. events. The words, evolution or revolution, calls the question, what changes are there? 50 years later refers to 2013 as the 50-year anniversary of the 1963 Civil Rights March on Washington. In August of that year, 100 years after the signing of the Emancipation Proclamation, the March on Washington for Jobs and Freedom, the original name, began with a rally at the Washington Monument and continued with a 1-mile march to the Lincoln Memorial. It was at the Lincoln Memorial that Martin Luther King Jr. delivered his famous "I Have a Dream" speech. At the time, the March on Washington was the largest demonstration for civil and economic rights in U.S. history, an incredible assembly of people of different races, religions, ethnic origins, who gathered to gain the full citizenship for African Americans, rights to equitable treatment and social justice for all Americans. Dr. King's dream, I believe, is active. It's not in the past tense. We live with the dream today. It includes a table of brotherhood and of joining hands. His dream is desirous of freedom and justice. His dream, our dream, is that children would not be judged by the color of their skin, but by the content of their character. While healthcare was not specifically mentioned in Dr. King's I Have a Dream speech, the focus of the march and the speech were on equal access to the American dream for all its citizens. A few years later, in 1966, in a speech to the Medical Committee for Human Rights, Dr. King stated that of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. The most shocking and inhumane. We know, you know, that healthcare disparities exist based on racial, ethnic, gender, and socioeconomic backgrounds. In 2010, the U.S. Department of Health and Human Services issued national guidelines with stated goals to eliminate health disparities. While this and many other legislative and programmatic efforts are being made to reduce care and outcome gaps based on the previously mentioned factors, as a health science community, we must keep at it. One team with one goal: to resolve various health disparities, including access to care, infant mortality rates, life expectancy rates, and the incidence of certain diseases such as diabetes, heart disease, and various cancers, among others. We have to keep at it. Dr. King's dream, our dream, remains an assignment for each and every one of us, an assignment for us all. We have to evolve and revolutionize the equity dream to gain meaningful traction, to mobilize our own thinking in creating creative models for model improvement, to innovate and identify new solutions to old problems that shrink the disparities, not only in incremental, but also in fundamental ways. Our University of Michigan Health Sciences Program, they work at this in many domains to address health disparities and inequities. Our health system has a cross-mission purpose with values aimed to shrink disparities, including provision of high-quality treatment of all individuals, regardless of their background, emphasizing the educational value of a diverse community, along with the intellectual value of diverse perspectives. Intellectual value of diverse perspectives from all communities. The researchers, educators, and practitioners at the University of Michigan play an important role in enhancing their collective understanding of the nature and reduction of health inequities. We will soon hear from one of our own faculty members, Dr. Carmen Green, on her work to address inequities in health and pain care. For those of you that don't know me, know that when you come into the same space that I am in, such as this room, you may leave with an assignment. I didn't tell you at the beginning, but I'm telling you that now to get you ready for what I'm about to say. On this celebration of the birth of Dr. King and the commemoration of 50 years since the Civil Rights March in Washington, I encourage you, I implore you to be inspired and to reflect on the evolution and revolution of Dr. King's dream, where the needs of the many outweigh the needs of the few or the one. Ask yourselves, what can I do towards building an increasingly diverse and inclusive system of health care, benefiting the various communities which we serve? Ask, can I take this dream to a new and better place? Actively seeking solutions will lead to meaningful change. It starts with each of us. First of all, servants of all, we shall transcend all. Thank you. Now, next for our musical enjoyment, please join me in welcoming the Michigan Gospel Chorale, to be followed by Verita Nix, who will introduce our keynote speaker, Dr. Carmen Green.
Lift every voice and sing till earth and heaven ring with the harmonies of liberty. Let our rejoicing rise high as the listening skies. Let it resound loud as the rolling seas. Sing a song. Sing a song. Sing a song. Sing a song full of the hope that the present has brought us. Ooh.
We want to give them another applause as they're walking off. Thank you very much. It occurred to me, I was thinking about getting up here, and I'm in a diverse group, but one that may not be aware that often when what is referred to as the Negro National Anthem is sung, everyone stands. But I didn't model that. So, but I wanted to share that with you. My name is Marita Nix. I'm Director of Organizational Effectiveness and Diversity for the health system, and I have had the pleasure of chairing the planning committee for the MLK Symposium this year. I want to thank you for coming, and I am sure we have quite a treat for us in our keynote speaker today. Thank you, Tony, for introducing the day for us. I'd like to, before I introduce our keynote, I'd like to recognize our committee, many of whom are in the room, some may be in the hallway. And I'd like them to stand so that you can see them. I'd like to start with Sharmika, who is in the corner, Abinagar, Patricia Coleman Burns, Chanel, got to talk into this mic, Chanel de Guzman, Larry Grant, Kenneth May, Alicia McCall, Debbie Mitchell, Melody Vanoy, Cassandra Willis Abner, and I'd like to give a special thanks to the lady in the corner, Charmaine Ward, I usually know her name, who is leading coordinating this event this year. Now I'll introduce Dr. Green. Dr. Green is a member of our health system. She is a University of Michigan faculty member, a professor of anesthesiology, obstetrics and gynecology and health management and policy, and a practicing anesthesiologist and pain medicine physician. She is also co-director of the Community Liaison Corps, director of the Healthier Black Elders Center, and director of the Dissemination and Health Policy Corps for the Michigan Center for Urban African American Aging Research at the University of Michigan. That was a lot to say, Dr. Green. Dr. Green has received acclaimed fellowships from the American Association of Medical Colleges Health Services Research Institute, the Hedwig Van Ameringen Executive Leadership in Academic Medicine, Mayday Pain and Society, and the Institute of Medicine of the National Academies, Robert Wood Johnson Health Policy. She is an international expert on pain and health disparities, women and minority health, and health policy. She has received many honors for her work, serves on many scientific boards. They are listed in your program. She is an elder member of Alpha Omega Alpha National Honor Society, Medical Society, and the Association of University Anesthesiologists, and an elected member, fellow of the New York Academy of Medicine and Gerontology Society of America. I will let you read the rest of her accomplishments and her service to the academic community, and I'd like you to welcome Dr. Carmen Green.
Good morning. I thought we were going to start in the morning, but it's good afternoon. You guys could be a little bit more enthusiastic. Good morning. So we've knocked down a microphone down here. Try not to step on it too much. And for Dr. Oman, who says I'm being silly when I don't wear these, I thank you for the kind introduction, Rita and Tony. I'm truly very honored to be here today to celebrate the life, the legacy, and the work of the Reverend Dr. Martin Luther King. It's an historic day if you think about it. At 12 o'clock, the president takes the oath of office, and it's a national day of service, and none of this would be happening, not me standing in front of you, if it weren't for the work of Dr. King. So we have a lot to celebrate, but there's still much more that we have to do. So Dr. King transformed our lives. He transformed our lives by the power of the written word, the spoken word, and through nonviolent action. Our country was forced to face and live out its creed and act on behalf of the millions of Americans who lived in the shadows, who suffered the pain of injustice, carried an unequal burden, and whose requests for freedoms went unheard. The pain of segregation and discrimination were eased by his work, and they no longer waited on the sidelines. I also would like to thank a few people for coming, the MLK Symposium Committee, especially Verita Nix and Charmaine Ward. I don't know where my teleprompter is, but that'd be a joke. That is clearly above my pay grade. And I know that you had other choices, and so I'm really glad that you chose me. University of Michigan leadership, including Regent Darlow, my friends, colleagues, and supporters. I thank our student learners today who started 27 years with a teach-in of the Martin Luther King Symposium, which brings us to this moment in time. They inspired Dr. King throughout his journey, and they continue to inspire us today. I also thank our patients and community members who entrust their care to us and are the reason for our work. Dr. King did not do this work alone. In fact, he benefited tremendously from the wisdom and counsel of his mentors, Dr. Benjamin E. Mays and Gandhi. Despite having fear, he was empowered by their courage and their wise counsel. They walked hand in hand in nonviolent resistance, in prayer, and with song. On August 28, 1963, as Dr. King shared his dream of a new age of equality and an end of racism and discrimination, there was also Rabbi Richard Hirsch. Maybe he should have been a doctor, but he was. He did heal spiritual wounds. So, Rabbi Hirsch often walked with Martin Luther King Jr. On that day, on August 28, 1963, there was a 7-year-old girl who was sitting on the steps of the Lincoln Memorial. He had big dreams for that girl. That girl was his daughter. She was 7 at the time. That young girl, watching from the sidelines, would become Ora Hirsch Peskovitz, who our Executive Vice President for Medical Affairs, nearly 50 years later. The people who walked with Dr. King potentially faced jail, rabid dogs, fire hoses, beatings, and psychic as well as physical pain for belief and pursuit of justice in their time. And the opportunity for people to have a seat at a lunch counter and enjoy a soda. They paid for a ticket that they may never use and for a dream that had been deferred. I stand here today in front of you this afternoon as their daughter and granddaughter on the behalf of many others who are the very essence of what they fought and died for. Although I was not alive for many of these moments, I've been fascinated by this time period in which the moral arc of this country bent towards justice, but did not break. I have benefited tremendously from my family and mentors. I specifically acknowledge the two people who I care the most about, Thaddeus and Ashley Green, and Ms. Fakazny. They're my cookie people, they're my chicken soup people, and they cost me a whole lot of money. I acknowledge my research team and my trainees who have continued to invest in this work. I thank my mentors, both new and old, for selflessly investing in me and watching me grow. I hope your return on investment is better than my 401k. I believe Lester Montz, the provost, is here, who was one of the first people to welcome me to this campus when I was an intern. I specifically thank Dr. Gilbert Oman for coming in on the red eye, and Martha on the red eye. He needed friendship. I would say that you were the first person to recognize the importance of my work when only my mother knew. You look beyond race and you look beyond gender. And you encouraged me to take a path, to create a path, and you would not allow me to leave academic medicine. I thank James Jackson and the Program for Research on Black Americans, who did not know anything about mentoring physicians, but they did so anyway. They taught me how to be an interdisciplinary scientist. They nurtured my creativity, and they supported my spirit all the way through the path of tenure, and then allowed me to continue to hang around. You were more than caring. You cared when there was not much more for me to give. You were my thought partners. You were my chicken soup people, and that was not for a season, but it was for a lifetime. So I pay homage to you today. The overarching theme for the MLK Symposium this year is 50 years later, the evolution of Dr. King. To this theme, the program committee asked me to talk a little bit about myself, my work on health and pain care inequities for minorities and women across the lifespan. So I will talk today about the history of health disparities, and will weave in some thoughts in regards to the civil rights movement and Dr. King's dream for us. I will share some of our work on Photo Voice, where people tell their stories and then add narratives to it. You will not see today bar graphs, p-values, or odds ratios. I heard some. Well, all righty then. So finally, we'll end up with what I consider a hopeful dream for 50 years from today, a dream for 2063. So my mother was a very wise woman and well-read woman. And if she were an extremist, she'd be a creative extremist for love. She would say, "You are my horse, and I'm going to bet on you to win, place, or show." She said, "There are three things you own: your name, your word, and your story." She gave us the stories and the narratives in which we needed to live by and to live for, while reminding us that the ancestors expected us to live authentically and fully, even if it made us unpopular. In 1963, when Martin Luther King Jr. had his dream, my mother also had a dream for her children who were yet to be born. As an Air Force kid, I traveled broadly and started school in Germany and spoke fluent German. I lived in places where there were two black kids. One was myself, the other was my brother. He doesn't really count, but service was really expected. I learned to pick potatoes in support of the food pantry in Caribou, Maine. The pain of the work, the difficulty of the work became up close and personal when I worked in migrant clinics in medical school in Michigan. The military also teaches you to be flexible and adaptable, and it teaches you that people are more like you than unlike you. Every mother, whether she's in Frankfurt, Germany, Burns Flat, Oklahoma, or in Flint, Michigan, tells her child to slow down when they're running near the water. Before Roots, My mother traced our family back to the late 1700s. So I am the proud great-granddaughter of slaves, of free people of color, of Cherokees and Choctaws, and Irish immigrants. People whose service was often dismissed. Their voices were unheard. Their journeys were long. Their burdens were unequal from birth until death. The ancestors shared stories with us to guide us, to inspire us, and to give us strength. I learned about a man, John Posey, a free man of color, who was so fair that he could pass, and his brother did. My grandfather chose not to live in the shadows with fear as a companion and enlisted in the 31st Regiment of the U.S. Colored Infantry, organized at Hart's Island, New York. He would chase Lee through the hills of Virginia and be present the day that Lee surrendered at Appomattox. When one of my uncles started dating a white woman, the family left the stinging pains of racism when the Ku Klux Klan chased them out of town. As an 8-year-old, I remember going to the cemeteries in Fairbury, Illinois, where their headstones were. Well before Rosa Parks refused to give up her seat and started a revolution, John Posey's grandson, Emmett Posey, would be shot in World War I, play in the old Negro Leagues, and become the first black police officer in the city of Grand Rapids. One day his superiors told him, you cannot arrest white people or discipline white officers. Papa quit, giving up the security of a pension, but living courageously with his dignity and self-respect to raise my mother, his granddaughter. He died before his great-granddaughter would receive his grandmother's Bible as a graduation gift for medical school. I do remember de facto segregation. My mother was looking for our very first home after spending a lot of time on bases. And the realtor told her, the good news is that there are no colored folks in this neighborhood. They found solace in her light skin, the way she spoke. But I think it's important that, the most important thing was that probably that she decided to leave the kids at home. I first realized the power of narrative to embrace the art and science of medicine when I was invited to the Rockefeller Center's Rockefeller Conference Center in Bellagio, Italy. It's a place where artists and scholars convene. It's where Verdi wrote one of his operas. They spark each other's creativity, they create community. And I was there for a conference on narrative pain and suffering. I learned the power that narrative might have to transform medicine and health and pain care inequities. I reflected during the conference on Sir William Osler's statement, it is more important to know what kind of person has a disease than the disease itself. But I ask, whose stories do we listen to, and when do we hear them? From my perspective, the chief complaint is a contraction of the person's story. Consider a 1-year-old female with viral myocarditis versus Sparkle Carr is a 1-year-old living in Saginaw, Michigan. Her mother is always at her bedside, and her mother is alone. And she's scared, very scared. Sparkle has been sick for a long time, and her family can no longer afford to take more time off work. So at that time, I wanted to be a pediatrician. I was on my first medical student rotation, and the attending took a great deal of interest in me because I wanted to be a pediatrician. We were rounding in the ICU. It was Sparkle's first birthday. She had beautiful honey almond skin and an engaging personality. We were writing progress notes when Sparkle went into cardiac arrest. Her beautiful brown eyes opened when our chest compressions were effective, and they closed when they weren't. My attending kept imploring her, saying, "Sparkle, hang in there. Sparkle, come on, Sparkle." We spent 2, maybe 3 hours before Sparkle died. Somehow I think that my face should not have been the last one that she saw. But I shall never forget the anguish of her mother, the pain-ridden, shrill scream that she had, my attending's tears, and the faint light that came through the stained glass window of the chapel. So, for me, in my photography, I like black and white, and it's really the shades of gray that provide the richness and nurture my writing. And I would say that Bellagio is a beautiful, pristine place. But I started thinking about healthcare and pain care inequities in a fundamentally different way in Bellagio. I realized that we must be willing to listen to patients' stories, and we need to be able to listen to them actively, not passively. We also needed to have humility when we listened to these stories. And so it wasn't enough just to have cultural competence. We needed to be humble as we heard their stories. It was a turning point in my career. Today, most of my research hypotheses are generated by listening to patients' stories, listening to their unequal burdens and their unheard voices. So I contrast today the beauty of Bellagio with the struggle for human and civil rights. I contrast the beauty of Bellagio with our national struggle to reduce and eliminate health and pain care inequities. I contrast the beauty of Bellagio with the sickness that is in our healthcare system, where we, the moral leaders of the free world, spend more money per capita for problematic access, differential care and decision-making, variable quality and outcomes, and increasingly unaffordable care than any other industrialized country. I contrast Bellagio with Michigan, who has one of the highest rates of maternal mortality in the country, and higher than many developing countries. The United States lags behind Cuba in life expectancy. So one cannot think about health and pain care equity without considering the civil rights movement and our painful legacy of discrimination. We must look back 150 years, at least 150 years, to the Emancipation Proclamation, the offspring of the Declaration of Independence. In fact, this is essentially where Dr. King began his I Have a Dream speech. 50 years ago, a great American in whose symbolic shadow we stand today signed the Emancipation Proclamation. The momentous decree came as a great light of hope to millions of Negro slaves who had been seared in the flames of withering injustice. It came as a joyous daybreak to end the long night of their captivity. So health disparities are not new. They were actually first identified after the Civil War when the health of the American Negro was so bad that there were proposals to re-enslave them. These crippling health and pain care disparities still exist and persist for Native Americans, Asian Americans, African Americans, Latino Americans, as well as some low-income individuals today. The biggest disparity is in life expectancy, especially for Black men who die earlier than any ethnic or gender group. So I think about Dr. King at 34 years of age, the time that he gave this speech. Was he hypertensive, diabetic, or have a pain problem? After all, he was stressed, had been oppressed, was discriminated against, and lived in segregation. This is before we consider things like the dogs, the jailings, the stabbings, and the bombings. How long would Dr. King have lived if he had not been assassinated? So, in the 1960s, there was a great deal of attention paid to the role of race in the context of civil rights. But in actuality, Dr. King made very few specific references to health. In the last few years of life, with the Poor People's Campaign, it is clear that Dr. King was shifting his focus to the dehumanizing effects of poverty in the context of human rights. Of all the forms of inequality, injustice in healthcare is the most shocking and most inhumane. Now, there are no actual transcripts. Tony alluded to this earlier. There are actually no transcripts from that talk. I've looked, I've asked, I've called. But there are some people who remember that talk. Fitzhugh Mullen, you guys know him, right? So I talked to Fitzhugh Mullen, who's featured in the book, The Good Doctors. And many of the people, so personal communication suggests that actually Dr. King did not say inhumane, and that he said inhuman. So, born out of anguish and born out of pain, I believe that Dr. King realized that social, political, and economic justice requires justice in healthcare as well. So, it'd be more than a decade before Shulman wrote this landmark report in the New England Journal of Medicine, a study using actors who presented with chest pain. It hurts here, it goes here. Doctors were asked to provide treatment for several patients. But who are these people? Are they black, white, or something else? If you grew up in my family, they would all be in the same family. For me, these two guys, they look the same. Like some woman has dragged them to the doctor. You know it's true. But if you're in South Africa, what is white now becomes colored. It all depends upon context. Who received the best care? Who received the worst care? Women and minorities received the worst care. The Surgeon General of the time, David Satcher, could not explain this variability in decision making. So nonetheless, it is an important American issue. In fact, both Republicans and Democrats introduced legislation aimed at improving minority health and reducing and eliminating disparities. In an increasingly female, aging, and diversifying society, the Shulman article points to some critical things. One, acute pain. But also, it talks about the fact that we do not all have the same access to health care, and we do not all benefit from the health care that is provided. So, the Institute of Medicine reviewed some data, 700 pages worth of data on health disparities. And they got people in the room who believed they existed, other people who didn't believe it existed. And they only spent about 3 pages on the context of pain, and then they focused on acute pain, and cancer pain. That would be enough for me to start a career. So at the same time, I was a pain management fellow and participant observer. I was listening to the stories of our patients with acute, chronic, and cancer pain. I wondered why we asked some people certain questions and not others. For instance, why is it that we asked every single woman whether she was physically or sexually abused, and we never asked the men? We jotted down this response very carefully, but we never asked the men. Somehow, male gender was supposed to be protective of the pain of abuse. I would say we failed to ask. We failed to assess. These omissions and the lack of data on pain care was what prompted my career and became the genesis of what I called Unequal Burdens and Unheard Voices. This is one of our photo voices. Just raise your hand when you're finished reading. Okay. So this patient actually had chronic pain, and it wasn't until she actually developed cancer that her chronic pain was actually treated. Minorities are much more likely to rate their health as poor than whites. They are more likely to die of 12 of the 15 leading causes of death than whites. Immigrants have better health than their native-born counterparts in the United States, and as the length of residence in the United States increases, their health declines. For most therapeutic procedures, minorities receive lesser procedures, lesser quality care in regards to their procedures. These differences persist even if we control for socioeconomic status, health insurance, stage and severity of illness, comorbidity, and the type of medical facility where they receive the care. Overall health disparities cost this country $229 billion between 2003 and 2006. So pain is a thief in the night. It steals physical, social, and emotional health, leaving behind depression and anxiety, sleep disturbance and disability, and diminished ability to participate in work and family activities. Most of the research has not focused on the unique implications for women and minorities and for their families. What happens to their children, to their partners, to their parents? What else has pain stolen from us? Pain is associated with many chronic diseases such as cancer, diabetes, and HIV. A recent IOM report tells us that 100 million Americans live with chronic pain. The number is probably higher than that because they did not include children and other vulnerable populations. 40% of patients who have postoperative care have pain during that period. 55 to 90% of cancer patients experience pain. Chronic pain costs us more than half a trillion dollars per year to the U.S. economy. Chronic pain is one of the major causes of healthcare utilization and disability, disabling more people than cancer and diabetes combined. Clearly, there will be emerging areas for new health policy. So the other part of pain is that there are differences, disparities, and inequities in the pain experience as well. Women, minorities, and the elderly are at risk for having difficulty accessing care, having differential assessment and treatment, and poorer outcomes. For instance, when minorities presented to the emergency room with a long bone fracture in comparison to whites, minorities received lesser analgesics. The same is true for cancer, where there's a failure to assess and there's been a failure to treat. Our physician studies show that women consistently receive lesser quality pain care than men, regardless of their race. We have shown this for breakthrough pain, the pain that has been associated with accelerated hastening mortality. Has been shown to decrease their quality of life. We've also shown this for cancer-related chronic pain. So I spent a year working on Capitol Hill. Dean Williscroft told me I would probably work harder than I did here, but we won't say that to the company. But my major goal was to stretch myself, to be a participant observer. I knew how to be a doctor, but I wanted to go beyond my comfort zone. So as I learned from Sister Rosalind Hinstebeck in my 9th grade Latin class, primum non nocere, first do no harm. It works out in medicine, the Senate, and in life. It's weird because at the table when you're writing these pieces of legislation, I was the only person who had written a prescription for anything. That may not surprise you. But I recall the stories of patients and the frequency with which patients experience pain, and the fact that many patients fail to receive state-of-the-art pain relief. It was this work that led to the National Pain Care Policy Act and the Institute of Medicine report, Relieving Pain in America, which I showed you earlier. The other thing, being a participant observer in Washington, D.C., is that you see some of our societal ills up close and personal. Although we pass them daily, we rarely acknowledge our homeless citizens. Many are veterans of foreign wars. Their emotional and physical wounds and pain is present if we dare look. We never really see homeless children and their families, yet 10% of the homeless are children. Do we ever miss their laughter? Who's going to tell their story? It happens someplace else to someone else. Disproportionately, children in foster care are children of color who will most likely age out of foster care with significant emotional wounds. In the United States, an important predictor for health and well-being remains where you live in your class. I can walk Gingy Girlfriend Green, my Australian stumpy-tailed cattle dog, with little concern in my neighborhood. If I'm in an airplane and I get bumped up to first class, a very good day, and the plane has to land in the middle of the Hudson, not so good a day, I have a lot more space in which to wait for help. But I would say that I can get anything in the pharmacy that I need. That's not the case for many communities. When managing pain, there are a lot of things I have in my toolbox, whether we're talking about physical therapy, counseling, medications, and nerve blocks, but in certain neighborhoods, you cannot get your prescription fills. So I want you to think about having the ability to finally get your pain assessed, get your pain treated, and then you can't get the prescription filled in your community. We showed that when you compared Michigan pharmacies, that those pharmacies in minority neighborhoods to those in white neighborhoods, 90% of them had sufficient supplies. When you look at the minority neighborhoods, only 50% has sufficient supplies, showing that class is not protective for minorities. Low-income whites have better access to pharmacies and having their medications filled than high-income blacks. When we looked at class across a group of patients who similarly presented to the pain clinic, we found that class, again, was not protective of the pain severity or the disability that followed. So the IOM confirms that pain is a problem and that we are all at risk for developing a pain problem. Take a wrong step off as you're getting out the car. You can develop a pain problem. We're all at risk. The committee supports the need for comprehensive interdisciplinary pain care. And they talk about it actually as being a moral imperative. They also note the conundrum of opioids. And I would ask us to consider as to whether or not the lack of utilization by minorities is potentially overutilization or appropriate utilization by whites. I think about that in the context that there's no data to suggest that minorities are more likely to divert or more likely to be addicted to medicines. So the IOM reports the importance of preventing pain, the role for patients and clinicians to work together, and it talks about the need for public health and community-based partnerships in order to manage this epidemic. Now the next slide I'm going to show you is another photo voice slide. Just raise your hand when you're finished. So, as a nation, we rarely talk about the more than 47 million Americans who live in places where they have difficult access to dental care, and the 17 million children who received no dental care in 2009. Beyond infection, poor oral health is associated with diabetes, heart disease, poor birth outcomes, and pain. Medicaid does cover children's dental care, but finding someone who will provide that type of care can be a challenge. Such was the case for Diamante Driver, a 12-year-old who lived in Prince George, Maryland. And this story was really, again, one of those transformational stories when I worked in the Senate. It cost $75 to pull a tooth. Diamante had a painful tooth, could not find a dentist. Finally found a dentist, but by that time, his abscess in his tooth had spread to an abscess in his brain. $250,000 later, Diamante Driver dies. So I suggest that if Dr. King was the drum major for peace, that Diamante Driver is the drum major for oral health. So, as we advance to the closure, we have to address the painful realities of the academy. The world is rapidly changing. Today, 47% of our children less than 5 years of age are racial and ethnic minorities. We will be diversifying higher education. Okay. However, these populations, racial ethnic minorities, are not included in some of the science that we do. And to advance the science, we must include representative samples. And that this is central to high quality science and inclusion science. However, I also contrast with the fact that we do not have representation in those who are providing care and those who are generating the new science. The Institute of Medicine and the National Academy of Sciences have discussed the fragility and the leakiness of the academic and health sciences pipeline, and our need to confront the gathering storm where racial and ethnic minorities are rarities. These reports also support that underrepresented minorities and women often study questions that are particularly relevant to underrepresented groups, but may not be perceived as being in the mainstream. They often lack mentors and are perceived as working alone. Thus, it's not surprising that these populations often leave the academy at alarming numbers. 50 years after Dr. King, the recent report by Ginther and sponsored by the NIH reveals that similarly prepared blacks are less likely to receive R01s than whites by 10 percentage points. It follows that if we are to eliminate health and pain care inequities, we also have to fix educational equities, and we also need to have a place for everyone at the table. But in the meantime, I wonder what we have lost. As a great society, we must recall that our strength is in our diversity and our ability to see through multiple lenses. We are all called to use our hearts, our heads, and our hands. But I also ask us to consider, are we capable of moving towards a vision of a great American society without thinking about the others who share the planet with us? Is health promotion the ability to access high quality, affordable, and equitable health care and pain care part of the vision for some, or is it a vision for all? I ask, can we work together? The schools of social work, nursing, public health, pharmacy, dentistry, in medicine to confront these problems and actually break down some of the silos that exist? Are we able to listen and embrace different stories without judgment and with humility, even if we become uncomfortable? Is this vision for the future consistent with people dying before their time? Most people do not realize that Dr. King made two similar but very different I Have a Dream speeches. One in Detroit on June 23rd, 1963 at Cobo Hall, and another, the more famous one, which was delivered at the March on Washington for Jobs and Freedom on August 28th, 1963. As I conclude, and in concert with the spirit of the day that we celebrate, this historic day, I believe we have accomplished a great deal. But I also believe that in these challenging and complex times, we still have a place and a need for dreamers. At this historic moment is a time for big, bold dreams backed by persistent and urgent action. The opportunities to close the health and pain care equity gap are tremendous. In 2063, the United States will celebrate the 200th anniversary of the Emancipation Proclamation. In 2063, we will celebrate the 100th anniversary of I Have a Dream. So today, on January 21st, 2013, I invoke Sparkle and Diamante, Julian and Rosa, John and Emmett, Maya and Langston to create a dream for 2063 from our mothers and fathers for our sons and daughters. And so this afternoon, even though we face the difficulties of today and tomorrow, I too have a dream that is deeply rooted in the American dream. I have a dream that one day this nation will rise up and live out the true meaning of its creed and will recognize the words of Jefferson that all men are created equal. They are endowed by their Creator with certain unalienable rights, that among these are life, liberty, and the pursuit of happiness. I have a dream that 50 years from today, on January 21, 2063, that our sons and daughters in Benton Harbor and Copper Harbor will break bread together, go to school together, and live together as brothers and sisters. I have a dream that on that day, every child will go to school and come home from school, lunchbox in hand, to tell their parent what question they asked that day. And that violence against children, and anyone else for that matter, is an historical remnant of the past. I have a dream that my children's children will live in a nation where children are wanted and loved. That no child is born in poverty and no child goes to school hungry. I have a dream that every child learns how to play a musical instrument, can read and do arithmetic at grade level, and will graduate from high school on time. I have a dream that our leaders will have dismantled the cradle to prison pipeline, because a cradle to college pipeline is available and successful. I have a dream that each child will be judged by the content of their character and not the color of their skin, disability status, or where they were born. I have a dream. Yes, I have a dream this afternoon that we realize that we can be both powerful and peaceful beyond measure. And that we are whom we've been waiting for. I have a dream that all elders are living with dignity, security, and respect. Their wisdom is valued, and their stories are heard. I have a dream that our soldiers experience peace in our time. The physical and mental wounds of war are healed as they decree war no more. I have a dream that no longer will people be disabled due to pain and suffer disproportionately or die before their time. I have a dream that devastating diseases such as cancer can be cured, and that the healthcare costs associated with surviving a catastrophic illness no longer cause a family to be bankrupt. I have a dream that equity and equality are as deep and clear as Lake Superior in the spring, and the water is warm enough for us all to jump in. With this faith, we will be able to hew out of the mountain of despair a stone of hope. With this faith, we will go out and transform dark yesterdays into bright tomorrows. With this faith, we achieve a new day where we transform the jangling discords of our nation into a beautiful symphony of brotherhood and community for all of God's children, regardless of ethnicity, gender, class, or sexual orientation. With this faith, we will work together. We'll pray together. We'll struggle together. We'll join hands and embrace each other while we stand up for freedom together. On January 21, 2063, as we awaken from our deep slumber with a clear conscience, and as the fog rolls away, we see the dawn, a new dawn breaking over the horizon. We look into our brother's eyes and our sister's face, and we say with courage and grace, with hope and humility, simply, very simply, as Dr. King taught us, and in the spirit of the old Negro spiritual, good morning. Thank God Almighty, we're free at last. Not certain even my mother would do that. I guess I'm supposed to ask if there are questions, thoughts, concerns. I would love to hear them.
You have a captive audience of patients right now.
Mm-hmm.
A captive audience of patients. Mm-hmm. And they're having pain. How do they best transfer that information to you? And as a clinician, how do I best capture that information from them?
So I think we, talked a little bit about having, active listening. I think when we think about I think about the game telephone. So, you had the two cans, one here, and then somebody hooked up to the other side. Or the game where you sort of passed information along. I always tried to sort of be the person in the middle and sort of mess everything up for everybody. But it's an art. So what does someone say? What do they mean to say? What was their intent? Were they standing like this, or were they standing like this? All those types of things come into play. And so really, communication is really an art. So it does require the physician nurse or whoever's providing the care to sort of be actively present and to hear those type of stories. It's not a passive process, and it's actually hard work to do it. And I also think we need to think about it in the context of being humble. Fortunately or unfortunately, there are the people who provide our care. Sometimes there's a disconnect just based upon class, and we have to sort of go back to some of our roots. I hope that answers your question. Yeah.
I've heard stories and testimonials of young people not receiving adequate pain treatment for cancer conditions, as well as sickle cell disease. And these families, inevitably, they end up going to a number of healthcare systems and being able to perform their own comparisons and seeing when the system really cares. I'm glad to hear that that the University of Michigan physicians most often do care and do give adequate pain control. But it's the families that are impacted, the young children who are the brunt of whether adequate attention is being given. The families are impacted, and they're part of larger communities that hear the story. So I'm wondering, who do you suggest be the advocate in these within these larger circles, these growing circles? Should it just be the physician, or should it go beyond the physician as far as advocacy goes?
Well, I think we all have to advocate for each other. I mean, we are a community. I mean, when a patient comes in with a problem, so whether they have Medicaid insurance, no insurance, or Medicare, Aetna, we're all paying for this. I mean, fundamentally, we're all paying for that. So at some level, there's, I think about the Hippocratic Oath. I think about the oaths that many of the people who are physicians took, because I think nurses take a different type of oath. No one goes out to purposely, I don't believe purposely, provide people lesser quality care. And I think that at any point in time, we can all look at sort of our practices and say, I could have done this better. So I think it's important for the patient, one, if they're able to actually advocate for themselves. But I think this is why we need to be thinking about this really in much broader conversation. So I think about the role of social work. I think about the role of public health. We've got lots of partners who help us to think about these things. And so whether that comes from focus groups to empower, it's your mother. Don't hang up on her. Okay. So I think, we really have to have very different types of conversations. And I think that, we could all benefit from learning how to actively listen in a very different way. And that's the reason why when I showed you those slides, I didn't speak. I wanted you to hear that voice without hearing my voice. So hopefully I answered your question.
Great answer.
I think you mentioned like a Pain Care Act that you helped work on when you were in DC. And so can you speak about what was actually in that act and if there are any other pending legislation that directly pertains to pain management and care?
Yeah. So, I was fortunate. I didn't go to the Senate to work on pain. I actually wanted to be as far away from pain as possible, but some things people find out that you're there. And so I had the opportunity. It was funny because we had talked about it before, many years before, and I kind of said, where's disparities in this conversation? Where's disparities in this conversation? It's kind of a mantra. And so this piece of legislation came up, and it was really kind of a unique piece of legislation in the way that we did it. Really sort of, we took a bicameral, bipartisan approach so that when the piece of legislation came through, it could actually go through pretty easily. There are a lot of different things that happened so that it didn't get really passed during that period of time. But when the Affordable Care Act came along, the legislation was already ready to go, and so it went into the Affordable Care Act. The one thing I would say that really so there were a number of people who were pain advocates who really focused on pain. And it had gone nowhere. So one of the things that was incorporated was the Institute of Medicine report, which I felt like it was important for people to sort of think about this from really a scientific, data-driven perspective. But that's not enough. And so actually putting in a few words like disparities in the language got a lot of people who were who had not been interested in the piece of legislation until they saw the word disparities, particularly on the House side, really interested in the piece of legislation, and that really helped. So it really talks, so the IOM report, so I could say the pain care report, Dr. Noreen Clark co-chaired that committee. She's from the School of Public Health. She's prettier than you, Martin. Just, she, chaired that particular committee, and what we could have, from my perspective, there are a few pages on disparities, but I think we need more on that conversation. So a number of pieces of legislation really talks about the need for a public health approach to pain. It talks about, so really community-based, so again, that's where we could be partnering on lots of these things. The problem is that some of it's not funded. You may have heard that Congress is having some financial issues. Just saying. So some of it was unfunded mandates, so that's the next piece. There's the other part which really talks about workforce issues, because if you look at our studies and you believe our studies, which there's no reason why you wouldn't, or at least I think not, it talks about the poor education of all healthcare professionals. So I'm telling you, in an increasing aging society, pain is going to be a bigger issue. And in a society where we think about the disability that's associated, number one cause of disability is how much it's costing us. We got to figure this out. So I actually think that we will be really on the emerging part as it relates to pain, as really a public health and as a public policy issue. But anybody who's interested in the IOM report, you can actually download it. It's iom.edu, right? Okay. No, it's not .gov. It's edu. If you want the PDF, they don't charge you for it. That's the beautiful thing about the IOM. I mean, you can iom.edu, and you can look up the report. Yeah.
Thank you for a wonderful talk.
Oh, thank you for coming.
I was wondering, how do you recommend a patient who has received inadequate pain care, regardless of race, how do you think that they could help the system after they've realized that they've received inadequate care? Is there something that they can do to help?
Oh, I'm sorry, I didn't mean to cut you off.
No, I'm finished.
So I think the patients have, rights. I mean, you entrust your care to us, and we try to do the very best job that we possibly can. But I think we can always use feedback in regards to the type of care that we provide. I get the feedback. I mean, I'm in a pain clinic, so there's feedback, right? But I would say that, if you have comments or thoughts or suggestions, I believe that this leadership is really open to those type of thoughts and feedback. Okay.
Thank you.
So sometimes, in medical school, we'll have people come in and talk about their stories so that we can try to transform, how we do it. The one thing I just want to add to your previous question is that one of the things that we did, when we worked on the FDA reauthorization, and this is in the context of disparities, one of the things that had never been in the piece of legislation before was the whole conversation of race, ethnicity, and gender as it relates to outcomes. And so now that is actually incorporated with that and several other pieces of legislation. So, sort of like, we can have these things, and they're pieces of legislation or policies, but we need to make certain that we can think about this at many different levels.
Thanks.
Thanks.
We have time for one more question.
Yeah. Oh, she was sitting there patiently.
Hi, and thanks. I'm an educator in part, and one of my questions is, how can we best, most effectively educate our students who will be the healthcare providers in the future to put pain assessment and appropriate pain management at the top of their agenda, rather than as something that is just on a list of check-off questions that they have to ask?
Well, the one thing that actually, you bring up an interesting question, because there's so much this in the medical school curriculum. I'm just talking about medical school. I didn't, I wasn't smart enough to really go into nursing. I heard that. So I can only talk about medical school curriculums, and we really don't have a lot as relates to pain. Nursing curriculums, not a lot as relates to pain. Nurses have actually brought physicians to the table. The nurses were tired of, a patient being in pain and the doctor walking out the room. So they've really pushed this agenda. So their leadership is well noted. But I would say there's a lot of competing demands. And what actually happens, the thing that is actually, and we shouldn't have to have this happen for us to assess pain. In our studies, we've shown that if a person has had pain themselves, or if they've had somebody close to them have pain, it changes the entire conversation. Okay? So I don't need to break my other ankle in order to remember that. I was kind of young and foolish, but I broke my ankle. But I'm just sort of saying that, I think when we actively listen to voices, and really, actively listen, that will change some parts of the conversation. And I think that, again, pain has, how do we view pain? You gut it out. We watched, I don't know who won last night. I was kind of working on this talk. Who won last night, Thad? It's the brothers, right? The brothers are winning. Okay, they're both Harbaughs. And they talk about, you gut it out. Pain. Well, sometimes it's not appropriate to gut it out. So I think we have to change the conversation about pain in a fundamental way. And then recognize that it actually starts costing us. And our data suggests that if you have breakthrough pain in the context of cancer, and we show that minorities were more likely to have that, that it actually potentially hastens morbidity, and certainly hastens morbidity and mortality. So hopefully answer your question.